they asked me to send a urologist because they knew that we couldn't operate as gynecologists on male patients, not like that they can, not like in Belgium or in the Netherlands. So in 2013, we sent our first urologist to practice pure, meaning clinical and surgical, male infertility, in also in NYPH. So let's focus on what happened after 2013.
PGH na IVF lang, yes. Pero matagal pa yun?
In 2013, we did our first micro-test in the Philippines. I mean, before, it was all gross harvest on the testes, no microscopic investigation. So that we had our first micro-test and our first micro-test pregnancy also in Army. And then, because of the sudden surge of data, many patients coming in, many male patients coming in for male infertility management, we were able to come up with a big study in 2015. And this was a documented study on surgical sperm retrieval, and the results were published in the ASRM and also locally. Then, up to the present, we have reported improvements in harvest quality techniques, sperm selection, sperm survival, and more importantly, better pregnancies for male infertility cases. Yeah. From then until now, the problem remains the same. We do not examine patients as we have to. I mean, as a gynecologist, I can understand how you would feel in front of a male patient and then having to examine that male patient as part of the couple presenting with infertility. So, most often, if patients come to you, they refer that once to the urologist. But we want to change that mindset because a lot of male infertility patients are not managed well, nor are they seen well, not even by urologists. Urologists admit that they do not see infertility patients like they should be seen. And purely male infertility patients would account for 26%. That's big. And then combined male and female, another 28%. That's a big portion of infertility that's not managed well. Then we have guidelines from the SRM, the American Urological Association, but we do not have anything from the Philippine Urological Association. With us in Carmi, we follow the blend of the ASRM and the AUA, American Urological Association. And this we got from Will Cornell, their male reproductive medicine microsurgery unit. Okay. So if you're going to summarize that manual, this is what we are supposed to do when we see male infertility patients. First would be to take a good history, physical exam, ultrasound, semen analysis, hormonal exams if needed, and then genetic examinations. So let us concentrate first on what we can do as gynecologists in private practice. A thorough history would mean you have to take the duration of infertility, previous pregnancies, the health of the partner, medical illnesses and previous surgeries, medications, whether legal or illegal drugs, family history, childhood development, whether there was a history of torsion, trauma, and mumps, which is one of the most common cause for us in the Philippines. And according to urologists, they don't have a publishing. And it is important to take note that once you have the history, this is your male axis, not from the brain to the testes. So that from here, you can pick which part has to be given better attention or more investigation. Right. Next, you have to take note also that the hypothalamic pituitary gonadal axis for male and female, they are more or less the same, with one minor difference. After testosterone is produced, there's negative feedback to the pituitary and the hypothalamus, whereas for females, after estrogen is produced, there is positive and negative feedback. It's not just a pure negative, there's also positive. For males, it's easier, not a negative feedback from the time testosterone is produced by the testes to the hypothalamus and the anterior pituitary. So let's focus more on what happens here, the testes. After being stimulated by FSH, the Sertoli cells and germ cells start to produce sperms, while NH would support baby cells. I placed this green here upon the request of the urologists because this is the only hormone that you can give for such patients. I mean, if a patient is deficient in FSH, you give recombinant FSH. And you give HCG if a patient is deficient in LH. Take note that they did not put anything under testosterone because now, seldom would they give testosterone not unless there is a hormonal indication. Otherwise, they won't give progesterone, they won't give andriol anymore, especially if we have low sperm count. Considering that in this graph, you will see that once you give testosterone, whether by injection or oral, it's going to shut down the hypothalamus and the pituitary some more, so they don't give anymore. Not unless it is a documented case of low or absent testosterone. Okay, next. From here, from the hypothalamic pituitary gonadal axis, the next thing to recall would be this one. No, this is the simplified World Health Organization 2010 semen analysis. No, we do not have the fructose there. We do not have the vitality test. We do not have the other microscopic exams. Because we know that this is what clinicians would look at, and this is where clinicians can focus their management. Nothing else. Okay, a volume of 1.5 ml, pH of 7.2. The concentration is 15 million per. It's nice to know that the concentration of the semen analysis has gone down from 1971, 60 million to 15 million as it were now. It has gone down. But the World Health Organization also cautioned that the semen, the sperm counts of humans has gone down since after World War II to the present. The average before, they said, was about 80 million after the war. Now our average as humans is 27 million, I think, or 28 million. But again, this would be the minimum concentration as suggested by the World Health Organization. Motility 40%, forward progression 32%. And take note of the morphology, only 4%. There should be no sperm coordination and the viscosity not greater than 2 centimeters after liquefaction. Then they gave guidelines, especially for us clinical practitioners. See? Collection can be done at home where the patient is comfortable, provided the sample is brought to the laboratory 1 hour, up to 1 hour after collection, and the time of ejaculation is
So ayan,
taken
1 hour, within an
note
hour
of
pwede.
and known to the examiner.
Anong lagayan mo?
And then, another critical point, the laboratory should be able to magnify the sperm
Pwede na yun.
up to 1,000 times.
So within an
Usually, it's
hour.
only up to 400 times in our laboratories. No spillage of collected sample, otherwise the patient is advised to collect again. And abstinence of 2 to 3 days. Okay, 2 to 3 days only. Considering that the definition of primary infertility is regular intercourse at least 3 times a week. So we might as well convert that to intercourse every 2 to 3 days. So abstinence of 2 to 3 days will satisfy the definition. A specific collecting cup, and the laboratory standards must conform with international guidelines. So, how do you evaluate the named patient after taking history of the physical examination? I know that you will not be able to, there will be apprehension for you to ask your patients. No. But then, perhaps the best would be to get the orchidometer. This is an orchidometer. So it has a nice pouch, and then colors. Colors there. These colors would represent pre-pubertal testes, and this will be your reproductive testes, and these are your inflamed testes, color-coded. But then if you're going to buy, don't get this kind of beads. I saw this in 50 Shades. No, this is not an orchidometer. So, don't get that. There's an orchidometer now. And then, this will be another big problem, di ba? You will not be able to examine such patients. So for such patients, you might as well ask for an ultrasound, testicular ultrasound. No? Don't bother examining such patients. Then, this one, be familiar with varicocele. They say that it's common for Filipinos.
Ano hindi pa yung perfect?
And there was, I gave this lecture 2 weeks ago in Cardinal Santos, and what they noticed was not the abnormality. That's why I placed arrows already. They noticed the wart. So that's why I placed arrows here, and then I placed another picture of what the varicocele looks like. It's more common on the left than on the right, considering that the plexus of veins formed on the left drains into the renal artery at a perpendicular angle. It's not like the right side, which drains directly to the cava. The left one, it drains first to the renal artery. That's why varicoceles are more common on the left. Then, when do you refer to a urologist? Understand that there are only few instances when you should be referring to them at once after a physical exam. When you have a varicocele, antecedent testis, you notice anatomic defects like hypospadias, you have prostatitis, a hard prostate or a hard testis, and you cannot adequately assess the scrotal and anal areas. That's when you refer. Otherwise, continue on with your treatment. I placed this picture here because there is a real need for more urologists to undergo infertility training. This is one of the most common indications why we refer to urologists a varicocele. Most of the time, the urologist would do a mass ligation of the pampiniform plexus. And what happens is it also cuts off the arterial supply to the testis and renders the patient more infertile. This is Dr. Goldstein. He's a renowned urologist. He was the first to isolate individual blood vessels in the testis in order to have a good recovery. I mean, good recovery for the patient, good recovery for the sperms. So this is what we did in NYPH. Parang there was a big difference in the quality of semen analysis after such surgeries were done. Then, how will you manage varicocele? Do all varicoceles have to be operated on? Will it improve semen quality? Or will it improve serum testosterone? So several studies were done. And this is what the arguments for no surgery approach say. Varicocele will not improve sperm quality, but there will be improvement in the semen parameters. Okay. Next, there is IVF, no need for varicocele. So that's the argument. But then, here we know that not all patients will be able to afford IVF. So we still go for varicocele surgery, varicocelectomy, but then we have to be sure that we go into the hands of good surgeons with adequate experience in exposing and isolating the arteries. Otherwise, you end up with a patient who is more infertile than before. And then also, we advocate varicocele removal, the varicocelectomy, because it improves testosterone. So, if you improve testosterone, you improve brain in terms of physical pressure, memory, muscle, also the kidney, the bone marrow, the bone, the liver, and the skin. And there are several big studies here that have done this. The biggest is this one, varicocelectomy, in association with increase in serum testosterone. This is a big study. And they all point to the fact that we should advocate varicocelectomy, not just for infertility cases, but also for lifestyle and quality of life after 50. Next. So let us interpret the semen analysis. So I gave you the parameters of the semen analysis, and then this is a recall of what your hormones will do, no? And then it will be evident in the semen analysis. First, it is FSH that would initiate the spermatogonial sperm cells to produce the sperms. Then LH would be needed for maturation and testosterone for final maturation. The prolactin is there, but then it does not have a direct effect on the secretion of FSH and LH, but instead it is by competition with the receptors in the pituitary. Next. These are basal hormone levels in various clinical states. And what's important here is to know that a high FSH will almost always give you an impaired spermatogenesis. But a normal spermatogenesis does not mean that you will have normal hormones. Okay? Hypo here is hypogonadotropic hypogonadism. hypo is hypergonadotrophic hypogonadism or complete testicular failure, or you can lump here the Sertoli cell only biopsies. Okay, and here are the recommendations when you see the semen analysis. If we have an abnormal count and concentration, or when the report states that you have azoospermia, oligospermia, or there's a combination like oligosteno, stenoterato, oligoterato, then this is what we should do. You have to do endocrine evaluation with serum FSH and testosterone and or LH and prolactin. The purpose of which to identify those patients with hypogonadotrophic hypogonadism who will benefit with injectable FSH and injectable HCG. Now, if you recall the slide I showed to you regarding the HPG of the male, the urologist wanted me to put the green arrows. That's where you inject FSH and HCG. As gynecologists, that one I think you can do. You can well manage to inject hypogonadotrophic hypogonadism patients. 75 units FSH up to 3 times a week, and 2,000 units beta HCG 3 times a week. And then also for abnormal counts and concentration, a post-ejaculatory urinalysis. There are patients who would have retrograde ejaculation. You don't find all the specimen in the cup. Some of them are in their bladder. So urinalysis after ejaculation will show you those sperms. In fact, we have had several pregnancies already where the patient does not have sperm in the ejaculate, but people get the sperms from the urine, centrifuge, and then resuspended and then used for IVF. We have had several. Then for azoospermia, you centrifuge again, and then it is re-examined. Just to make sure that it is pure azoospermia rather than spillage or retrograde ejaculation. Also, for abnormal count and concentration, a transrectal ultrasound just to screen for BPH. All in all, the semen analysis, your history, and the physical exam of the infertile male is to differentiate what is obstructive or non-obstructive. Is it an azoospermia due to anatomical defect, or is there complete shutdown of the sperm factory? That's what we want to know. So for oligosteroteratospermia, the recommendation is IVF or ICSI already, no more insemination. Go straight. Based on the big study by Dr. Palermo and Schlegel of NYPH. And next, we had a big study also from 2010 to 2018. All the patients who had surgical sperm retrieval with azoospermia at the St. Luke's Medical Center, Army, we put those patients, and then we wanted to see what would come out of this azoospermic men. So the first publication was at 18 months. We presented it to the ASRM. Then the second one is still for publication, but we can share with you our preliminary result. The important finding is the bigger the testis, the better it will be for us to recover sperms. So that small volume, you can already tell your patients for prognostication purposes that there may be difficulty in retrieving sperms. Then The lower the FSH, the better. And these are the important predictors of micro-TSE, the testicular sperm extraction. For obstructive azoospermia, especially for those with infection, there is 100 sperm retrieval rate so that you can well assure your patients with nodularities in their vas deferens, or when you examine them, they have post-gonorrheal prostatitis or vas deferens infection. You can assure them that we will be able to extract 100% of the time the sperms needed for fertilization. Then for non-obstructive azoospermia, this is another surprising result for Army. For those with hypospermatogenesis, 95.7% we can recover the sperms. For those with maturation arrest, it's 72% compared to 25% worldwide. Ours was 72%. We were able to get. And then this one, the real azoospermia patients, after micro-TSE, 28.6 of them will give us a few more sperms capable of fertilizing. Then, so when do you request for anti-sperm antibodies? When do you request? If your semen analysis will show high clumping rate or there is sperm agglutination, if you have a normal count but low motility, meaning less than 40%, and if you are considering by history a break in the blood-sperm barrier, such as previous genital infection, arthritis, reversal of vasectomy, including basal division, mostly, and there is an explained infertility. Then, that one, if you still have a patient who would not consider ICSI. But for patients who are open to ICSI already, then you don't have to request for anti-sperm antibodies. It is wise to note that when you advise your patients, ICSI is most often done, meaning the sperms are injected right into the nucleus of the egg, because most of them, they will still want you to just overlay the sperms on the eggs and then let natural fertilization occur. That's what we do when we counsel patients in CARM. No, most of them, they would still expect natural interventions, like just put the sperms there and then let them penetrate the egg by themselves, rather than us putting in the sperms into the nucleus. And then when to request for genetic screening after semen analysis. No? By history, there is cystic fibrosis and congenital absence of pus, history and TB, when request for genetic screening. There is impaired testicular function, and there is non-obstructive azoospermia, meaning you have a full complement of semen but no sperms, or there is severe oligospermia. Then consider Y chromosome deletions. 70% of infertile males have abnormal karyotypes. 15% of azoospermic males have abnormal karyotypes. 5% of oligospermic males, they have abnormal karyotypes. And only 1% of males with normal sperm analysis have abnormal karyotypes. So if you see semen analysis that is normal, then you can assure your patients that only less than 1% of them will have chromosomal defects. So this is a typical history of endocrine and testicular failure, meaning it is up there in the pituitary. No? If you're going to recall the GnRH neurons, they travel, when they develop, they migrate from the olfactory focus up to the hypothalamus, di ba? And then they leave their neurons that will be necessary for stimulation. Sometimes this does not happen, especially for Kalman syndrome. No? Kalman syndrome, there is a deletion of the Cal1 gene. The Cal1 gene is over here, so that there is no migration of the GnRH neurons from the preform plate to the hypothalamus. And then these patients will become infertile also. Because those with Kalman syndrome, their defect would be on the centrioles, and instead of being organized like this, then the sperm tape becomes so disorganized and they become infertile. No? Sperms cannot swim. And then, if you have a patient with testicular failure, meaning there's no other course but to work out and do micro-essay. Okay? So you will have to refer the patient already to your urologist and to your reproductive endocrinologist. Then let's go to paternal age. No, parang in the past years, we've only been talking about maternal age as a cause of infertility. It now seems now that paternal age also has an effect on reproduction. This one is what happens if you marry an older man. No? I mean, past. Dito, sabi nila 30 at 40 and above. So that's the definition of parang male of advanced paternal age. So this is what happens. When a man is younger, she is more in tune with what the woman feels sexually. So that when they get to about 45 years old, they cannot function anymore. That's one reason why you have fertility in older men. Then paternal age will also mean decreased semen volume and decreased motility. This one we got from the recent lecture last week of the male infertility masterclass. And also, this one, aging males will have preterm births, low birth weight infants, achondroplasia, autism, bipolar disorder, schizophrenia, and decreased cognition in the offspring, in the baby. No, parang mas maraming magiging autistic na bata kung maganda yan tayo. And then, we had another study also in Army, but I couldn't retrieve the slide. But paternal age and its effect in IVF. There also it points out that we have less fertilization if the male is older, because here in the Philippines, we have a lot of patients where the male partner is 60 and above, and the woman is between the age of 20 and 40. Marami yun. So, decided to do a study, and the effect would be, there would be less fertilization for older men. And then, all of this is due to oxidative stress. No? As the male ages, oxidative stress plays a big role in the quality of the sperm. And it is cumulative. It appears to be cumulative according to the University of Oxford. And then, this oxidative stress leads to infertility. ROS, radical oxygen species, no? It destroys first the maturing germ cells, then it damages the DNA in mature sperms. Also, ROS, there is DNA damage leading to decreased sperm function and therefore infertility, and also This all, the DNA damage from all of these pathways would mean there will be impaired embryo growth and health of the offspring. This is also from the University of Adelaide. They had a big study for both animals and humans. Then next, when do you go for IUI? Okay. We have an abnormal semen analysis. Your first line would be IUI, except for there are only 2 instances. There's no need to do an IUI to go straight to IVF. OAT, oligostimulatory and testicular failure. Okay? Then IUI, it says in the book, the best pregnancy rate is at 18%. It is so difficult to pull in all the data from the laboratories, but what we found out, the best pregnancy rate would be about only 5%. No, 5% pregnancy rate for IUI. So much so that there is no limit with IVF. If you're going to factor in all the expenses that the patient would incur with regard to the dose of gonadotropins and the cost of the laboratory and the cost of the preparations, if you're going to present this to the patient, they would want to consider IVF rather than go through the whole gamut of 6 IUIs before transferring to IVF. An IUI would cost between 20,000 to 60,000. That's just the laboratory part. No medications. Medications would be it would range from 30 to 72,000. So that's already about 100,000. Plus the fees of your doctor, about 8 to 30,000. Let's say 100,000 average for one IUI stimulated IUI cycle. No? 6, that's 600,000. Probability of getting pregnant, 5% per try, or a cumulative pregnancy rate of 35%. That's what they are arguing now. So, they would rather go to IVF, especially if they are young, and their probability of getting pregnant is 70% with several eggs in storage, meaning with 350,000, they will be able to get pregnant 70% of the time, and yet they will still have a reserve egg for use later on, when after they have given birth, or if the pregnancy does not take place. So that's the argument that we've been hearing from patients. No? Parang, Doc, let's not do IUI anymore. We know the expense. Let's go to IVF. So we have to really educate them again and tell them that follow a certain protocol. But then some of them, they won't go for IVF. Medical management. This is just the gist of the medical management for male infertility. No, do not give hormones. Estrogen or testosterone, anti-hormones like clomid. Without the benefit of a zero hormone profile. Meaning, don't give them testosterone unless you know that testosterone is low. Otherwise, you're going to shut down the testes. Also, same with clomid, especially if the patient has normal testosterone profile. Then supplements, medical management, you give them glutathione, 500 milligrams a day, vitamin C, 500 milligrams a day, vitamin E, 400 units per day. They work only if there is radical oxygen species in their history, meaning they work in a high stress job, they're exposed to chemicals, they're exposed to radiation, they're exposed to harm. No, if not, then these supplements will not work. Then, dietary manipulations do not have a strong evidence. But according to, there's a new field in medicine, functional medicine, and then there's functional reproductive medicine. What they say is, even though you do not give them, you do not treat the infertility because of dietary modification, you are in effect treating their lifestyle. I mean, in the long term, they're going to get better health because of dietary manipulation. Maybe their first convention in the Philippines will be in May, I think. It's wise to be updated. And you're going to be posting this in the St. Luke's website. Functional reproductive medicine, functional medicine. Then there's a new field now which we want to introduce now that I'm standing with you of fertility. It's a relatively new field. It's not part of male infertility per se, but then it deals with fertility preservation in cancer patients. So a new society, a new organization was established last month, and the aim would be to help patients with cancer, especially the young ones, because 85% of cancers now are survivable, and many of them will need conservation, especially for women. We can keep the eggs, we can keep ovarian tissue, we can reactivate ovarian tissue afterwards, and then we can induce egg production again after chemotherapy. I think this is my last slide. I want to thank you for inviting me for listening to the
Thank you very much, Dr. Milia. Before, as Dr. Bon is trying to set up, I think we can ask ask the audience if you have any questions for Dr. Milia. Any questions? Sir, I have a question if they're not going to ask. The saying that size matters isn't applicable to infertility as far as male infertility is concerned.
size in terms of the testes, yes. The bigger the testes, the better, except when it reaches that size when it becomes inflammatory. And the size of the penis, yes, because we have to repair the micropenises in order for them to be
So girls, guys, size matters. Okay? Alam ko may nasasayahan dito. Nakikita ko na doon. Ayoko na sabihin ng pangalan, pero tinuturo na ko ng kaibigan ko. So again, size matters. If you think you have a problem with infertility, check your partner. Alam ko may isang tao dito, hindi pa na-check ang partner niya, pero nakatatlong anak na siya. So I think size really does matter. So any question? Another question? Naging English kayo bigla sa size matters, ha?
Sir, I made a request for hormonal growth time. Even if you have a normal scandal, just give me a request.
For normal semen analysis, I mean, you have the complete semen analysis, not just the motility, count, and morphology. You have the complete one no more. You have the fructose, the vitality, and what's this? The helix. There will be some semen analysis where you will have, this is just less than 1%. Normal semen analysis, but still infertile after 8 years. Then there is a test for vitality and the amount of mitochondria in the matrix.
Okay, I think we should limit the questions to those two only. So our second lecturer for today, talking on recurrent pregnancy loss. She's a fellow trained in the Reproductive Endocrinology and Infertility (UPPGH), a consultant of Perpetual Health Plaza Medical Center, Las Piñas, and Asian Hospital Center, and also the PRO of the Philippine Society of Reproductive Medicine Incorporated. May I call on Dr. Hina Irabon.
Hi, good morning. I'm Dr. Tan. And the topic assigned to me today, or this morning, is on recurrent pregnancy loss or RPL, which definitely is one of the most frustrating and difficult areas in reproductive medicine because the etiology is oftentimes unknown. No? And this is one of the most debated or hotly debated topic among clinicians and academics alike. So, sobra siyang hot topic or hotly debated, even its definition widely contested among societies. So RPL often causes an emotional frustration for our patients and a medical frustration for us clinicians. In part, this is because a definitive treatable cause is frequently found, and as yet, only a few of the factors that contribute to failed pregnancies have been clearly elucidated. So much so that even if you have comprehensively worked up your patient with RPL, in 50 to 75% of the time, you end up with nothing. Yung pala, unexplained RPL na pala siya. So RPL is a very broad subject matter. So para hindi ko naman kayo mabore masyado, I just concentrated or made my lecture concise and concentrated just on the very important questions that is important in our clinical practice. And at the same time, give you updates on RPL as well. Okay? I want to share with you my slides, so just a bit of a shameless ad for me. I uploaded my lecture in my WordPress site, it's Endocrinology, if you just want a copy of the lecture. Okay? So, the latest updates or the latest guidelines on recurrent pregnancy dose is by the ESHRE, that's the European Society of Human Reproduction and Embryology. If you want to download a copy of this, it's free. You just go to this website there, and then you can download that for free. Okay? So marami pa pong societies ang nag-publish ng RPL guidelines, but the latest would be from this society. But even our modern society folks is RPL guidelines. Okay. So one of the clinical questions, how many doses are required to diagnose RPL? In other words, ano ba ang definition talaga ng RPL now? Okay? The definition of RPL varies. Depende sa what society cater to. No? Varying definitions have included 2 or more failed clinical pregnancies. Pag sinabi natin clinical pregnancy, that's a pregnancy that's documented either by ultrasound or histopath. Meron ring definition of 3 consecutive pregnancy losses, which are required to be intrauterine. Now, these are the different definitions of RPL. Iba-iba kada society. No? So yung ACOG, 2 or more miscarriages. Yung ASRM, that's the American Society of Reproductive Medicine, defined it as 2 or more miscarriages na dapat clinical pregnancy. Meaning dapat yung pregnancy na yon, yung abortion, dapat documented by ultrasound or histopath. Not necessarily consecutive. Now, the RCOG and the COGS define it as 3 consecutive pregnancy doses na clinical pregnancy din. However, yung ESHRE is more liberal sa definition. So, 2 na lang. 2 or more miscarriages, not necessarily consecutive, and not necessarily clinical pregnancy. So, included na po nila yung non-visualized pregnancies, biochemical pregnancy, and even the pregnancy of unknown location. So, kasama na po siya doon. So, what counts as a pregnancy loss? In other words, who are the patients that we need to evaluate? Okay. So, if we go by the definition of ESHRE, ng REL, na hindi kailangang clinical pregnancy, then we include patients with a pregnancy that is confirmed at least by either a serum or urine beta-HCG. In other words, hindi na kailangan ng ultrasound. Pag positive ka sa pregnancy test, kasama na siya doon. Okay? So this includes non-visualized pregnancy losses, biochemical pregnancy losses, or pregnancies of unknown location. In the non-visualized pregnancy loss group, pregnancy losses after gestation at week 6 are included, where an ultrasound examination was only done after complete expulsion of the products of conception, or no ultrasound was done after bleeding. This includes pregnancies that would have been classified as clinical miscarriages in case an earlier ultrasound scan has been done. And we don't include, of course, ectopic pregnancy, so hindi siya kasama sa RPL count. So, molar pregnancies and implantation failure. The prevalence of recurrent pregnancy loss ranges anywhere between 1 and 5%. In nearly 50% of the time, patients with RPL, the underlying cause remains unknown. So, unexplained recurrent pregnancy loss sila. Now, if we define recurrent pregnancy loss as only those including the clinical miscarriages. Yung prevalence is a little bit low, ng 0.8 to 1.4%. But if we include those biochemical losses, then the prevalence is a little bit high, on a 2 to 5%. What are the known risk factors of RPL, or recurrent pregnancy loss? The two most important independent risk factors would be maternal age and the number of previous miscarriages. With previous miscarriage, the history of previous miscarriages as the most important or the strongest prognostic parameter for RPL. The number of previous miscarriages is very important. No? So, the higher the number of previous miscarriages, the higher the risk of miscarriage. As you can see here, after 3 miscarriages, almost nearing 50% yung risk of miscarriage was for the next pregnancy. Ganun kataas. The risk of miscarriage in subsequent pregnancies is 30% after 2 losses, and then 33% after 3 losses. So parang pareho lang halos, no? Walang pinagkaiba yung risk after 2 losses and after 3 losses. And this is the reason why, yung pagkakapareho ng incidence na yan, that's the reason why strongly suggested that there's a role for evaluation after just 2 losses. And ergo, yun yung naging basis ng ESHRE, kaya dapat after 2 losses lang you evaluate the patient with recurrent pregnancy loss. Now, you have the option of evaluating your patient earlier, especially if your patient is older than 35 years old, or the patient or the couple has a history of infertility. Okay? Another risk factor is maternal age. And as you can see here, the rate of miscarriage increases with advancing maternal age. Okay? You can see in this graph, no, that there's a sharp increase in the rate of miscarriage in women 35 years and above. And this is due in part because of the increasing rates of aneuploidy in association with older oocytes. So what does ESHRE say? ESHRE say, or recommends, that women should be informed that the risk for pregnancy loss is lowest in women aged 20 to 35 and highest for women aged 40 and above. Okay? ESHRE also notes that advanced maternal age is also a big factor when it comes to recurrent pregnancy loss. Also, the effect of smoking, caffeine, alcohol, obesity, and even being underweight. Sabi ni ESHRE, even being underweight is a risk factor for recurrent pregnancy loss. And lastly, stress. Yeah. So hindi na lang psychological ang effect. Even stress, says ESHRE, is possibly associated with recurrent pregnancy loss. Although, sabi ni ESHRE, although associated with stress or recurrent pregnancy loss, it is not a direct cause. There's no evidence that it directly causes recurrent pregnancy loss. Okay? So what are the causes of recurrent pregnancy loss? Couples who have had pregnancy loss in the past have 2 major concerns. One is, ano yung nag-cause ng recurrent pregnancy loss ko? And pangalawa, what is the risk of recurrence? No? Or what is the prognosis of a live birth after what I experience now? Okay. Unfortunately, the cause of RPL can be determined only in 50% of patients. So the unknown. It shows that only a few so-called etiologies of RPL is supported by evidence. And what are these etiologies that is supported by evidence? Genetic, anatomic, autoimmune, and endocrine factors only. So yung ibang theorized risk factors, etiology for recurrent pregnancy loss, such as infectious diseases, luteal phase defect, and so on and so forth, all of those are not supported by evidence. So only these 4, genetic, anatomic, autoimmune, and endocrine factors are supported by evidence when it comes to recurrent pregnancy loss. So let's start first with genetic. Okay. Approximately 60% of pregnancy losses are associated with sporadic chromosomal anomalies, and usually these anomalies are the trisomies. Okay. And in part, this is age-related. The risk increases in women over 35 years of age due to markedly increased incidence of aneuploidy in old age. In women older than 40 years old, the sporadic miscarriage rate approaches about 50%, close to 50%. And balanced reciprocal translocations and Robertsonian translocations are observed in about 2 to 5% of couples with recurrent miscarriage. Other genetic causes will include inversions, sex chromosome aneuploidies, and supernumerary chromosomes. Now, if ever lang po na you have a patient with a genetic problem, yung genetic factor po for the recurrent pregnancy loss, then you should advise genetic counseling for these couples. Okay? So genetic counseling is important when a structural genetic factor is identified, and the likelihood of a subsequent healthy live birth depends on which chromosome is involved and the type of rearrangement ng chromosome that is involved. So when one of the partners has a structural genetic abnormality, then we recommend pre-implantation genetic testing, that's PGT, amniocentesis or chorionic villus sampling for the offspring. Okay, so treatment options include pre-implantation genetic diagnosis for specific translocations with transfer of unaffected embryos, or the use of donor gametes, which is, of course, not allowed here in the Philippines. Now, knowing that the genetic factor is just, or comprises just 2 to 5% of the etiology for RPL, kailangan ba talagang magpa-karyotype yung parents? Kailangan ba? The answer is yes. Okay, why? Because karyotyping of the parents can provide prognostic information for subsequent pregnancies. So, for example, the parent has a reciprocal translocation and karyotyping. Then you can tell the couple that your chances of miscarriage for your next pregnancy is about 50 to 70%. So, bawa, Robertsonian translocation naman ang meron sila, then their chances of miscarriage for the next pregnancy is about 30 to 50%. So, more of advising them, no, yung halaga, no, of doing this karyotyping. Should we karyotype also the reproductive or the process of conception? Answer is yes. Okay? Again, for prognostication. Just to provide prognosis for subsequent pregnancy outcome. Kasi, if it turns out na euploid, yung karyotype ng products of conception, then chances are, next pregnancy niya, pag mag-miscarry man siya sa next pregnancy niya, chances are that fetus will have a normal karyotype, which is a good prognosis. Okay. Now, what does Escher say? Actually, Escher says that the products of conception and the parents are both not routinely recommended. However, you can use this genetic testing for explanatory purposes and for prognostication. Okay, so that's the use. Okay, next. Yung antiphospholipid antibody syndrome. So, ito medyo favorite natin ito. Nothing has changed naman much about yung criteria for ATS. But I just want to remind, ganoon pa rin, one clinical and one laboratory criteria. But I just like to remind, kasi usually ang alam natin, di ba, yung 2 to 3 consecutive miscarriages, malamang apas ka. Pero don't forget kasama sa obstetric criteria, if you have a patient with at least one morphologically normal fetus at or beyond 10 weeks na namatay. Okay? So, bawa, you have a second trimester patient na namatay yung baby, tapos morphologically normal. So, but that's one indication. Another is when you have a patient with a premature birth, with premature birth of a normal or morphologically normal neonate before the 34th week age of gestation because of preeclampsia. Okay? So, kasama siya sa criteria. Kasi minsan, akala lang natin yung 3 consecutive to consecutive abortions or miscarriages. So, yun, don't forget those indications. Those are part of the obstetric clinical criteria. Okay? How do we treat APS? Yeah. How do we treat? Ganun pa rin, no? Low-dose aspirin and heparin. Yun yung sinasabi sa Escher guidelines. You might have encountered some patients being given prednisone by the immunologist. Actually, Escher says administration of prednisone does not improve pregnancy rates. As a matter of fact, it may be associated with increased risk of gestational hypertension and gestational diabetes. Also, ESHRE says na hindi rin po recommended ang giving LIP and IVIG. Okay, so what ESHRE also says is that for women with RPL, we recommend screening for APS. So yun yung lupus anticoagulant, ACA, IgG, IgM, and the beta-2 glycoprotein antibodies. Okay? For the anatomic, ganun pa din, still the uterine septum or septate uterus is the most common congenital anomaly with approximately 4.8% of women having this. Okay? But for the acquired anomaly or uterine anomaly, it's the uterine fibroids. It's the most common, especially the submucous type of fibroids. Other congenital mullerian tract anomalies that may be associated with RPL include unicornuate, didelphys, bicornuate uterus, and arcuate uterus. Now, the evaluation of uterine anomalies is easily detected in the office with the use of 3T ultrasound, hysterosalpingogram, or MRI. MRI is just an alternative to 3D ultrasound because ESHRE recommends the use of 3D ultrasound to investigate anatomic causes of RPL. Now, if you see a septate uterus, then that is amenable to hysteroscopic surgical correction. And unfortunately, we don't have any surgical corrective options for the other mullerian abnormalities. So, ESHRE guidelines of 2017 says that all women with RPL should have an assessment of the uterine anatomy, and the preferred technique to evaluate the uterus anatomically is the use of transvaginal 3D ultrasound. Ngayon, kung hindi daw po available ang transvaginal 3D ultrasound, a good alternative would be MRI. We go now to the hormonal metabolic factors. Okay? So the hormonal metabolic factors that are associated with RPL are diabetes, thyroid dysfunction, and hyperprolactinemia. Okay? So you should evaluate your patients along these lines. This fact, yung second line dyan, might be something new for you, but no, whereas before, we know naman na yung TSH values between 4 and 5 MIU per liter were once considered normal. But nowadays, no, there's a consensus that's emerging that TSH values above 2.5, kahit sabihin pa nila na normal naman yung 4, normal naman yung 5. Pero now, more and more clinicians are actually treating patients who have TSH values above 2.5 MIU per liter, especially the patients who are infertile and with RPL. Okay? So, galing din to kay ESHRE and the ASRM guidelines. So, uncontrolled diabetes and hyperprolactinemia are associated, as I've said, no, with increased pregnancy loss. So, what does ESHRE say? ESHRE recommends screening for TSH and TPO antibodies. And also, actually, hindi naman dapat routinely tinetest ang prolactin, but it is recommended for patients with clinical symptoms of hyperprolactinemia. Ano ba yung clinical symptom niya? Diba, usually it's oligomenorrhea or amenorrhea. Okay? How about infection? Yung torch. Not anymore recommended. So don't request for torch panel anymore for patients with recurrent pregnancy loss, because there's no convincing data that infections can cause recurrent pregnancy loss and no clear indications for routine testing. Okay? And the use of antibiotics is not supported by the evidence. And this one, I've already mentioned this to you kanina sa earlier slides, that lifestyle factors such as cigarette smoking, obesity, cocaine, alcohol, caffeine, and stress are all associated with RPL. But there's no evidence that it directly causes RPL. Just association lang. Now, this is very important. So, Doktora, ano na ngayon ang ipapa-order ko sa pasyente ko? Kumari, may dumating sa clinic ko, may RPL. So, what constitutes a full workup for RPL? Ito na. So, this is the recommended panel for a full workup of RPL, recommended by ASRM and ESHRE. So, di ba sabi ko sa inyo kanina, 4 lang naman yan eh, yung may evidence, scientific evidence talaga. Genetic, APS, anatomic, and metabolic / endocrine. Okay, so for genetic, we do genetic testing. Really sorry, carrier genetic testing. Kasi, I think sa NIH, here in UP Manila, they still do karyotyping. Pero kasi ang problem kasi with karyotyping is hirap kasi i-culture yung tissue eh. So, I think in other countries, they do other methods of genetic testing. So, for APS, of course, you know naman the APAS panel. And then for anatomic, you do the 3D ultrasound. If 3D ultrasound is not available, you can do MRI. And then investigate also with or without hysteroscopy. Actually, mas maganda if you also do hysteroscopy for investigation of anatomic causes of RPL. And lastly, screen for thyroid, prolactin, and diabetes. Okay? So what is the treatment for RPL? Actually, they already mentioned some of the treatment for recurrent pregnancy loss in my earlier slides. But just to summarize, just to remind you, baka nakalimutan niyo na kagad. Okay, for uterine factors, again, ulit-ulit na, 3D ultrasound is the best. Okay, or MRI is an alternative if you don't have a 3D ultrasound facility in your institution. If you see a septum, which is the most common cause, anatomic cause of RPL, then you refer please for hysteroscopic resection of septum. If there's a submucous myoma, then you refer again for hysteroscopic resection of myoma. Okay. If she has to test for APS, ito po yung hiningi natin, yung APAS panel. And then, treat with heparin and aspirin. For endocrine abnormalities, again, as I said, test for thyroid, prolactin, and diabetes. Okay, so these are the treatment options for that. For genetic, do genetic analysis of both the mother and the father and the products of conception. Okay? So, if meron po kayong structural genetic abnormality na nakuha sa report, then please refer your patients for genetic counseling. And pwede rin siya i-refer sa REI for possible PGD. Okay. So, ito, meron kasi tayo, di ba, 50% na lalo nyo sabi ko, unexplained yan. So, I will not tackle on the unexplained RPL, but some clinicians give progesterone supplementation, Paston, and immunomodulating treatments, although no consensus on these treatments, and pre-implantation genetic screening. So, this one, yung mga iba pa, out of yung mga iba pang theorized etiologic factors, such as infection, luteal phase deficiency, these are not really supported by evidence. Pero some clinicians do manage with using progesterone supplementation and antibiotic treatments. Okay? Now, lastly, ano prognosis of a live birth? Okay? Well, I'm ending this with a happy note. Kasi even if medyo nakaka-depress ang RPL, no, the prognosis for women with a history of recurrent is very favorable. It's often favorable. Kahit na wala kayong minsan intervention nagkakaroon sila spontaneously ng mga live births. No? So, women, as long as you corrected what's wrong with your patient, the women who are younger than 30 have approximately a 75% chance of live birth within 2 years. That's how you can advise them. No? Whereas those who are 40 years old and above, yung chances of live birth nila is a little bit lower, 40%. But not bad, no? 40% is still good enough. Women with 3 miscarriages, the chance of a successful live birth is around 70%. Whereas women with 6 or more miscarriages, a little bit lower, 45%. Okay? So in summary, so RPL again, as defined by ESHRE, is the loss of 2 or more pregnancies. This now includes biochemical pregnancy losses, not necessarily consecutive. It is nearly 50% of patients with RPL underlying cause remains unknown. Okay? Maternal age and the number of previous miscarriages are two of the most important independent risk factors for miscarriage, and cigarette smoking, caffeine, alcohol, obesity, stress, and environmental exposures are all associated with RPL, but there's no evidence that they directly cause RPL. And the other etiology include genetic factors, APS, anatomic, and metabolic and hormonal factors. These are the only 4 factors that is supported by evidence. No? That's really causing recurrent pregnancy loss. And lastly, so the recommended workups, so along those 4, no? So genetic analysis, screening for APS or the APS panel, 3D ultrasound or MRI, and screening for thyroid, prolactin, and diabetes. Okay, thank you for listening.
Photo just time. Kasi every time kasi nakikita ka na, gamit na lang ano mo ha. Hindi yan alam mo complain ng discharge.
Thank you very much, Dr. Aerobon. So, no questions muna tayo at nagmamadali tayo. Ang konti. Oo, mamaya na yung mga tanong pag may oras tayo ng konti. So, kailangan ko nakakita ng tumataas lahat ng cellphone ng tao kahit walang showbiz personality sa harap. Nung may table, taas din ng cellphone. Another table, taas din ng cellphone. Just, na-overwhelm na ang stage, wala man lang ang tao. So, to give us the third lecture on age as limiting factor in the success of IVF, he took his residency in obstetrics and gynecology and fellowship in reproductive medicine at the University of Illinois, Abraham Lincoln School of Medicine in Chicago, Illinois, USA. He is a diplomate of the American Board of Obstetrics and Gynecology, the first chair of the regulatory